I remember when the EMR rolled out, when we started doing that early 2000s, it was, treat the patient, not the record. And I think it's the same here. It's treat the patient, not the alert. It's a piece of the picture that you're looking at, but it's not defining the care.
Carolyn, what's the burden on the nurse at the bedside as a result of all this?
I mean, these tools are for clinical decision support. They're not to make the decision for the individuals.
Oh, that's a really great point.
Just one more thing, Greg. And I think what Carolyn said is the most poignant thing that if anybody walks away from this podcast with, is that these are decision support tools. They're not the decision makers, right? So I've been a nurse for 37 years, I think. Yeah. Anyways, we used to have rooms where we had a monitor tech, and typically it was a registered nurse who could read the bank of monitors. I mean, there's like 36, sometimes 40 telemonitors, right, that are up there. Now, management decided we don't need anybody in a room looking at monitor banks all day long. You know what happened? We had streams of EKG tape just all over the floor. Alarms not being responded to, patients going into demise. It became a real big liability and a real big patient care issue. So they reverted it back and said, okay, we're going to reintroduce the monitor tech. And they gave the system back. It's kind of some of those things that come up. Hopefully we can learn from those and move forward with this.
Welcome to Beyond the Blueprint, a podcast designed to empower healthcare professionals, enabling them to improve care delivery through integrated design and technology innovation. My name is Gregg Malkary. I'm the Managing Director at Lighthouse Health Tech Advisors. Whether you're redesigning a hospital, launching a new digital initiative, or just curious about the future of healthcare, then you're in the right place. Let's explore together what's possible when we go beyond the blueprint. Now, before we dive into today's discussion, I want to recognize our valued sponsors who've made Beyond the Blueprint possible, Simplify Medical. With their support, we're able to bring you insightful conversations around healthcare design and innovation. If you enjoyed today's show, I encourage you to subscribe so you never miss a future episode. Today, we're talking about AI in nursing and what happens when alerts reach nurses before the hospital has actually assigned help. A nurse may receive a high-risk alert while already caring for another patient. The alert may be correct, but does it give the nurse more time, another set of hands, or a clear way to change the work in front of them? That's the problem. AI can identify a patient who may need attention first, but it cannot send another nurse, call transport, or make a physician respond. Recent national surveys suggest that more than 6 in 10 hospital nurses work in settings where AI can influence which patients are flagged, prioritized, and watched for early signs of deterioration. Over the next 30 minutes, we're going to examine what happens when AI guidance reaches the nurses, but no one has been assigned to act. The central question is, does AI change the work or add pressure to the nurse who's already carrying the workload? Today, to help me unpack this, are 3 nursing leaders who understand how AI affects inpatient workflows, escalation, and patient safety. We have Troy Seagondollar, a former Kaiser Permanente nurse and informatics leader who has seen firsthand how technology changes the work of the bedside nurse. We have Dr. Daniel Gracie, a nursing informatics and clinical operations leader at Medical University of South Carolina, who studies how system design changes what nurses see, document, escalate during care. And we have Dr. Carolyn Harmon, professor of nursing informatics at the University of South Carolina, who focuses on AI policy, leadership decisions, and how they shape how nurses make decisions during the care process. So with that, why don't we start the moment AI alert reaches a nurse who's already caring for another patient. Troy, I'm going to direct this first question to you. When an alert arrives when a nurse is already with another patient, what determines whether the nurse can act right away?
What determines what they're going to act? Really, honestly, it has to do with the severity of that alert. So not all alerts can be responded to immediately, and the level of acuity of that alert needs to be defined in the process and the development of it. The biggest issue we have typically when an alert comes in is, what is the nurse doing at that at that moment in time. If I'm actually busy with a patient, it's very unlikely that I'm going to have the ability to leave that patient, disengage, and go follow up on this alert. So you hope that something is going to be in place that allows maybe a team-based alert system where I not only get the alert, but someone else may get the alert. The biggest issue we run into is alert fatigue. So you end up getting all of these alerts that someone else has defined as a priority, even though you're busy and you're engaged with a patient at that moment in time. So those are the types of things. The classic issue is when I neglect either the alert or the patient sitting in front of me, somebody is going to miss out on the level of care that I can give them. So we have to be very, very prudent in how those alerts are structured and set up and how they're prioritized within the system.
Right. Hey, Daniel, what keeps a correct alert from changing the nurse's next action?
I think it all depends kind of also how they're being alerted. Just kind of thinking of that also, because if you're not in the chart, you might not see the alert. Someone else may see it. So it's kind of one of those, are they going to mobile devices or just seeing how they're being alerted? And then it comes into just reprioritization, kind of call it shaking the snow globe whenever you kind of have your plan set for the day. And then, everything gets shook up and you're constantly reprioritizing, seeing who needs what, and then delegating as you can based on that. But it's a challenge trying to see with some of the alerts, making sure it's valid. The old telemetry thing, telemetry would be going off and the patient was brushing their teeth. So, things, people would go running in and drop everything and then, oh, false alarm. So things like that, where it's just kind of learning how the systems operate and how to reprioritize as they come in. What level of alert is it? Is it a high, medium, low? Is it just that, hey, somebody needs water, or hey, somebody, a lab result might be back, but it's not a critical lab. So it's not as important as something, you're running a fluid or you're running a particular drug in and it comes back and it's really bad. If you got a heparin drip going and, their labs come back and PTT, INR and things are really high and it's like, oh, stop it quick, versus, if, their potassium's fine and they're getting IV fluids, it's not a big deal. So it's kind of taking that whole situation and reprioritizing based on the needs of everything going on.
Carolyn, I'd like to add on here. When the alert's seen but no response happens, where should accountability sit?
Well, accountability is very difficult and challenging to narrow it down. Who is accountable? Is it the AI model? Is it the creator of the model? Is it the institution, or is it the nurse or another clinician? So that's where you run into the issues with accountability and artificial intelligence. I would like to add to some of what Trey and Dan just recently spoke about. I have some research on unintended consequences of the electronic health record and cognitive load. And my concern about all of this that we are talking about is when you have alert fatigue and you have too many alerts coming in and it's a false alarm, it's a false alarm, it's a false alarm. It's kind of like the old concept of crying wolf, to where you go into what's called an alert fatigue mode. And alert fatigue is basically cognitive overload. And that's when we get into poor patient outcomes, concerns around patient safety. And I became a nurse because I had a loved one to pass away from a medical mistake. And so a lot of the work that I do is around how can we improve patient care? How can we improve patient safety? How can we reduce the challenges and the distractors within the environment that causes alert fatigue and cognitive overload? So those are some of the things that I'm personally concerned about, as opposed to accountability. I mean, who do you hold accountable? That's when you get into root cause analysis. You drill down, because 9 times out of 10, it's not a person, it's you. I mean, most people go to work. Most people become clinicians because they want to do the right thing. They do not go to work saying, I'm going to make a mistake today. They go to work wanting to do the right thing. It's, do we have the environment set up for them to do the right thing? And so that is where the concern comes in. It's usually systems, communication when you get into root cause analysis, workflow. There's all kinds of things that those are the things that we should hold accountable.
Well, that's an excellent point. We actually did a podcast on clinical surveillance. So now that we have all the alerts and alarms that are going on at the bedside, we now have 20 plus clinical surveillance alarms that are going on at the same time. Do we really know what the cognitive load that a person can handle with the current patient load they have? Are there processes and standardization in place? Because I think a lot of nurses or informatics professionals I've talked to indicate you kind of mentally check out after a certain point.
Well, there's all kinds of components that's involved in cognitive overload. You also have to take into consideration nurse burnout. How many shifts if you look at team steps and a lot of the data and the research that's associated with quality and outcomes, you have to look at how many shifts has that person worked? How long have they been on their current shift? Have they had a break? I mean, there's numerous things and factors that come into play, as well as staffing and some of the other environmental factors.
Thank you, Carol. So the alert can point to the right patient, but doesn't necessarily give the nurse more time or more help. The nurse must still decide which patient can safely wait. Troy, a new alert arrives when the nurse is already with another patient. What risk does the nurse take by leaving the room?
Well, in the immediate sense, obviously I'm at the bedside of this patient for a purpose and for a reason. So again, you have to balance that out. Not knowing what the alert entails and how it's transmitted is kind of the key aspect of when you build the system. I'd like to say one thing, about the structure of what is an alert and who actually defines the escalation or even the priority of those alerts. Many times what we see are people that haven't been at the bedside for a long time or are not at the bedside, defining what actually dictates an alert and the level of the priority. Not everything can be an emergency. If everything's an emergency, nothing's an emergency. And so that's what you have to balance out. So how do I, as someone at the bedside, engage with the patient, engage with the family? How do I know that this takes priority over what I'm doing right now? Now, no patient likes to hear the nurse say, yeah, I got to go, and walk away. Not in the middle of whatever procedure you're doing. I could be doing a dressing change. I could be doing a physical. Those are two totally separate processes. One of those, I cannot disengage. The other one, yeah, possibly I could walk away and I could go check and see, does this take a higher priority than what I'm doing currently? But we have to keep those nuances of care. That's why the whole human aspect of care and creating these linear diagrams in the IT world are extremely difficult to explain to a programmer or somebody that's developing the system. Informatics nurses do it very, very well. Most of us have, 20 years of experience. And so we can ask those questions to the clinicians and we can develop the alerts in those ways to make absolutely sure that we can capture those nuances of care and that we allow the bedside nurse, give them the best information in the best possible way to make the right decisions at that point in time. So those are the types of things we got to look at. But again, I just bounce off, somebody's going to miss out. Unfortunately, if there's no resource.
You raised a really valid point. What happens, because not everybody has 20, 30 years of experience. My wife's a nurse at Stanford, and there are many younger nurses who've freshly minted. What about if you don't have the clinical judgment and you have alerts that are coming out that don't have enough context? And you're forced to actually make decisions at point of care on what's relevant. Daniel, what are your thoughts on this? Where are we as it relates to people, processes, and tools and being able to address this type of issue? I got a full load. I got the alerts coming down. And I'd love to get your thoughts.
I think some of this goes back to, it needs to start almost in nursing school, reminding them to treat the patients. I remember when the EMR rolled out, when we started doing that in the early 2000s, it was, treat the patient, not the record. And I think it's the same here. It's treat the patient, not the alert. You need to take that into context. It's a piece of the picture that you're looking at, but it's not defining the care. Nursing is keeping the human touch, keeping that stuff into adding or keeping it in healthcare and adding your expertise to say, this is a big deal. This is not a big deal. I can, let this one slide, or it's not an urgent need. Sometimes I almost wonder kind of with prioritization and stratification of high, medium, low risk. I remember when we did the EMR, or the EMRs were rolling out, and a lot of the unit secretaries were worried their jobs were going away. And it's like, no, it's just changing because they were used to taking off orders and things. I mean, with the alerts the way it's coming now, at some point, are you going to need someone to triage them, or some sort of stratification to say, hey, if Troy's doing a dressing change, he needs to come now, or hey, he can get this in 15 minutes, because like he had said, everything, if it's emergent, then nothing is, and you kind of risk the overload. So how do you balance that with stratification? And do you need an air traffic controller, like a alert triage person, to say, hey, this person is showing signs of sepsis based on these latest lab results. You need to, we need to start this, or, they're not showing it as much of a concern or not. So I think it's really going to be interesting to see how these alerts come at us, and just seeing how we integrate ways of nursing to handling these on top of everything else that we're juggling with discharges, admissions, keeping patient flow moving because someone's coming out of surgery and you need a bed. Well, whoops, the alert just went off. So, I think patient flow, things like that, and just making sure we don't impact too much when we're addressing these.
Wow, that's a great point, Daniel. Do we actually need a facility that's actually some kind of call center that's actually monitoring patients? But maybe, Carolyn, you could address that. And also, what's the burden on the nurse at the bedside as a result of all this? Especially if you don't have that central monitoring a set of nurses to provide air traffic control.
So basically, I would take a step back. If I was at a facility or organization and we were realizing that alert fatigue, alarm fatigue, all of those factors was an issue and a problem, and it was putting our patients at risk and our nurses in a environment that is creating, fatigue and burnout and all of the things that we have that are problems within nursing, I would take a step back and I would look at the workflow, the system, and let's think about the implementation. When we did implementation, did we include the appropriate people at the table during the design? And did we design the system to where we had input from the experts at the bedside? Did we have input from those folks who are in the workflow day to day? Because that is usually where the problems are. It's usually a systems problem. It's usually a workflow problem. And again, a communication problem. So that is where, when you're having too many alerts, too many alarms, those are usually your problems and issues. When you get into doing a root cause analysis, you take a step back and you look at the big picture. And that is where I think that you have like some middleware companies and some other companies like that can come in and help with those factors. If you are actually an organization that's struggling with that, if you're not struggling with it, then it could be, like you said, it could be, is it a people problem where it's, your novice nurses versus your expert nurses, and how can we, move them from novice to more proficient or higher levels of expertise so that they feel more comfortable with their own clinical decision making? I mean, these tools are for clinical decision support. They're not to make the decision for the individuals.
Oh, that's a really great point.
Just one more thing, Greg. And I think what Carolyn said is the most poignant thing that if anybody walks away from this podcast with, is that these are decision support tools. They're not the decision makers, right? Now, just a tale, right? So I've been a nurse for 37 years, I think. Yeah. Anyways, so in days of past, working on telemetry units, we used to have rooms where we had a monitor tech, and typically it was a registered nurse who could read the bank of monitors. I mean, there's like 36, sometimes 40 telemonitors, right, that are up there. Patients are all out in the rooms, they're walking the hallways, they're in other units, things like that. The sole purpose of that nurse was to prioritize the alerts that the system was developed to alert us to, right? So we would look at those, interpret it, and determine, is this an emergency? Is this just kind of something that needs to be documented? Or is this like normal for this patient, right? So that level needs to be appreciated, and it needs to be brought forward to where we're at now. What has happened and what evolved, and I'm still on the whole telemetry thing, management decided we don't need anybody in a room looking at monitor banks all day long. Let's just put them in the central nurses station and allow anybody walking by to look at those when they alarm and to look at the strip and determine is this, what level of priority is that? You know what happened? We had streams of EKG tape just all over the floor. Alarms not being responded to, patients going into demise. It became a real big liability and a real big patient care issue. So they reverted it back and said, okay, we're going to reintroduce the monitor tech. And they gave the system back.
Wow,
It's kind of some of those things that come up. Hopefully we can learn
powerful
from
point
those
you're
and
bringing
move
up,
forward
Troy.
with this.
So what happens if an alert moves from one nurse to another during a handoff? How do we make sure that someone actually responds? So there's the idea of an isolation of these alerts and alarms coming at you. But what about when you're actually coordinating with other members of the care team, which could be nurses or other members of the care team? Do those tools exist, or does it depend on the expertise and the experience of the nurse to be able to coordinate effectively?
Again, it comes down, I think it's experiential knowledge. It really is. I mean, what may be an emergency to a new nurse or a nurse that's had some personal experience with this being an issue in the past, they're going to make that a higher priority personally, right? Regardless of what the system says. That the system may say that it's a lower level priority alert, but yet through my experience in evaluating the patient, understanding the nature of their admission, understanding the sequelae of their disease, is this a priority or not? And I may see those subtle little things that others do not, and even the system was not designed to pick up on.
Hold on, this is great, but this goes back to the question we had in the previous segment about accountability, right? If something's happening, who takes accountability? How do we know it was actually addressed in an adequate manner to ensure the highest level of patient safety and satisfaction?
But that's the mystery.
And any thoughts, Carolyn or Daniel?
I think some of it goes to the escalation pathways of these things also. Making sure that, leading to burnout and things like that it's not just alerting or like a pager going off. Someone's doing a dressing change and it keeps going off as it's going up that something needs done. But, making sure, hey, if this person doesn't address it, what's the chain of escalation? Does it go to a nurse manager, a charge nurse, a care coordinator, some other role that's kind of overseeing, making sure that, hey, the sepsis alert's gone off 3 times and nobody's, acknowledged it or kind of started the chain of ordering antibiotics or things like that. So, again, I think it depends on the case, but there's real risk here if it's things like sepsis and those alerts aren't being followed up on with all the work with surviving sepsis and things like that. Making sure that antibiotics are started timely, early signs and symptoms are recognized quickly, appropriate labs are drawn and redrawn, serial labs, things like that. These are system processes. These aren't just, hey, alert the nurse, which I think a lot of people think, this is going to tell the nurse to do these things and the process is going to work. No, it's a process. So this is a piece that has to be integrated into the larger process.
Are the tools, because we're talking about AI, right? Have the tools evolved where they're actually providing the appropriate context? Is it integrated with the EHR? Are the appropriate tasks being able to be distributed to the appropriate members of the team where there's a logical progression and it's actually tracked and at least reduce the likelihood of a bad event occurring?
What he's trying to say is that technology does not fix bad workflow. So you have to have a foundation.
Correct.
And exactly, it makes them pop up a lot faster than you ever realized, and it exposes many of those. So you have to be really, really prudent in looking at, okay, how are we doing it now?
No,
and how
that's a great point. Can you guys elaborate a little bit on bad workflow, right? Is bad workflow a common problem across the U.S., right? There's certainly not everybody is MUSC, right? That was a comment.
Well, basically, it goes back to when you planned and designed the tool for the implementation, did you look at your current state workflow and then try to improve it as you move to your future state workflow, which would be your escalation and pathways and all of that particular information? Did you include the appropriate people? I know that during many of my years of implementation that we a lot of times forgot the clinicians and we forgot to have them there when we were doing the workflow, the work of this. And there was a particular process that was 32 steps that we later optimized down to 6 within the EHR. But basically, those are the things, like you said, when you automate bad workflow, that is a primary example.
But hold on, you're bringing up a great point because some of the other podcasts we've had that have looked at AI indicates that's the big challenge, right? We have leading edge tools coming out, but they don't map on top of workflows that may be 10, 15 years old.
Or you've got
Right.
workflow for, a large health system, and you're trying to put them in a rural health, a rural hospital. Yeah, they might not have students or attendings on call 24/7. Things, their lab might shut down in the evening, different things that they may not have access to. Or if you're trying to, roll these out across the health system, it might work fine in an inpatient setting, but if you have free and urgent care centers or things like that, making sure the context is appropriate in areas that it might travel out to.
Well, and to let you know, I mean, even in the large systems, of which I worked for a long time, when you've been to one hospital, you've been to one hospital. So you may have a grand, a master plan at a national level or a regional level, but when you get down to that particular medical center and even down to the department, you have to step back and say, okay, what are the differences? What are the nuances in this particular location that we need to take into account? Now, many times you can adjust some stuff, but if you're trying to get a universal system to fit, the round peg in the square hole syndrome, you have to be very, very diligent and with the total change management aspect of it. Again, you have to talk to people. You got to bring the clinicians and say, okay, this is the proposed model. This is what we believe is the best way to go forward. Will it work? Is there something we can do? And, you're always going to have your innovators that say, yeah, this is great, wonderful stuff. Let's do it. Let's rock and roll. And then you got the others who are the naysayers and say, forget it. I don't want to do it. I have always tried to blend all of those people in the same room so they can have the debate, and I just stand back and take notes and then build a system around whatever they're talking about. And then, of
Troy,
course, that
I
needs to
don't
be
believe that
back
you're
up.
just going to sit in the background and just take notes. You're
I,
you're
yeah,
actively
well,
engaged.
I facilitate conversations, Greg.
Okay, I'll buy that again. Actually, you bring up a really interesting point. Is that because I know, Carolyn, you're involved with a lot of standardization work, right? Is this ripe for standardization, right? And at what level? Because as you mentioned, a hospital is a hospital, but what about when you have different environments? Some in rural areas like Bakersfield, California, versus being in downtown LA. How do we standardize and actually roll this out? Are the tools mature enough at this point? Or is this really the opportunity where in the first generation and the tools must continuously evolve and how they're integrated with the EHR?
So what I'm seeing, and Dan and Troy, please feel free to disagree with me, but what I'm seeing with artificial intelligence and artificial intelligence tools is actually the ability to customize. So like, I'll give an example. Now, this is an academic example, but you're able to customize the information to the individual. Like, for instance, in academics, when we incorporate artificial intelligence tools in our teaching, then those tools customize to that learner and to that learner's ability. And we're teaching them, to try to utilize the tools to develop competencies because, we have to have them prepared for the workforce and the workforce today, not the workforce of yesterday. And that's one of the key things that we're trying to do in academics to prepare them for the clinical role. But when I go to the clinical world and I assist those folks, whether it's through research or service or any of the other responsibilities that I have, what I have concern about is ambient intelligence is great, and it really is reducing documentation burden according to the feedback that we're receiving from the clinicians who are utilizing the tools. But my concern is Are they actually reviewing the documents? Because this is the downstream impact, is if you're not reviewing it, you're not correcting it, you're not editing it, that documentation is data, and data is what we use for clinical decision support. So then we are making decisions on that patient's care off of the data that has been incorporated and implemented into the EHR. And therefore, if it's incorrect, you can then be utilizing incorrect clinical decision support data.
There's a data governance problem, right?
So it's
Only as good as the data you have in there for
Yeah.
you to be able to automate and analyze.
right.
Junk in, junk out.
How hard is it to take the research that's being done in the academic community? Is it being applied at an accurate level within nursing environments, across the country? Are they able to embrace it, or is there a big disconnect between what could happen in theory versus what's actually happening on the ground?
Well, it depends on what kind of research you're conducting. A lot of the research that I personally have conducted is what we call translational science. You can conduct the research, discover the new knowledge, and then translate it into practice, because a lot of my focus is about outcomes. Currently, I'm working on a study that has been funded by the Duke Endowment. And we have an interdisciplinary team at the University of South Carolina where we are recruiting nurses to participate in a study where we are going to collect biometrics of those nurses. We're going to use VR, which is virtual reality, to have a not so great shift, which actually has alert and alarm fatigue and all of those things within it. We also are going to collect the data while they're doing some of their real life shifts. And then we're developing AI models to try to predict nurse burnout, because what we do know and what research that is out there is there are connections between nurse burnout and poor patient outcomes. So yes, I do think that something like this is translatable to practice because it is to help the nurse within practice. I also have a colleague, Dr. Sarah Donovan. She's doing a lot of ambient intelligence research. So her and her team is conducting a lot of research that then those who are creating ambient intelligence tools, they're utilizing to make the tools better. So yes, I do believe that the research is translatable to practice.
Wow. Guys, this has been an awesome session. Unfortunately, we're out of time, but I want to do one lightning round to provide some guidance to our listener base. If each of you could give us about 30 seconds on what's one decision the nursing leaders must make before the next AI alert reaches a nurse who's already caring for another patient, what advice would you give the nursing leaders that they could act on today that might reflect on some of the topics that we've spoken about over the last 30 minutes? Carolyn, why don't you go first?
I have a few points that I would like to make. One is make sure you have the right people at the table during decision making, and nurse leaders are phenomenal people to include at that table during the decisions, the design, and the implementation of these tools. Two is don't be a one-trick pony. That is that artificial intelligence tools, if you upload, I'm currently conducting another study where if you upload information into each of those tools, you do have different feedback. So make sure that you're doing what I call a synthesis, where you look at the information that you're receiving from varied tools, AI tools, and then you synthesize that information. And then the last thing is you are the expert, you're the clinician, and you always trust your gut before you do a clinical decision support tool.
Excellent. Troy, what would you like to add?
I think first and foremost is to recognize and understand that even though we call everything right now artificial intelligence, it's not. It's augmented intelligence. We must remember that without human decision making, we're really tying our hands to the future and creating a huge liability that I don't know where and how we're going to recover from. But we have never really relied on automation to be the ultimate decision maker. Will we attain that someday? I think at a low level, we probably will. But please don't go out, see some showware from some vendor somewhere who says this is going to cure all of your problems. Everything will be okay if you just implement our software. Don't believe it. We're just not there yet. It's going to take a lot of years and some very very insightful people to sit down and ask those very, very complicated questions as to, yeah, maybe we can do it, but should we do it? And is it mature enough to actually make a difference, not only for the clinicians, but for the patients that we care for?
Excellent. Daniel, why don't you bring us home?
Yeah, and tying into that, I think it's, don't get caught up in Gartner has the hype cycle. When things come, how it goes. Don't get caught up in the hype cycle, or you go to a conference and someone, promises you, I call it the rainbows and unicorns. Yeah, you're going to, end world hunger, wearing all this stuff, go to your frontline staff. Make sure you truly understand the problem first. Make sure you have the workflows mapped out, because if you already have issues in the foundation of your system, this is only going to amplify those. This isn't going to solve them or cure those, whether it's workflow, whether it's, immature adoption of, the tools or things like that. Make sure that you have a good understanding of your current state. Know your shortcoming. Don't make it worse by adding this tool to it.
Carolyn, Troy, Daniel, thank you very much for your time today. I'm Gregg Malkary, and thanks for joining us on Beyond the Blueprint. Thank you for listening to Beyond the Blueprint. Together, we're exploring how thoughtful design can simplify complexity, enhance patient care, and create meaningful change. If you found value in today's episode, make sure to subscribe and leave a review in order to help us continue the conversation. Let's reimagine healthcare together on Beyond the Blueprint.